Good afternoon, everybody, and welcome back. For those of you who don't already know me, my name's Sarah Hunak, and I'm the current chair of the SRP Webinar Committee, and I'd like to welcome you to another SRP webinar this lunchtime in partnership with AURPO on a subject that I don't know very much about actually myself, so I'm quite excited to learn more on veterinary compliance issues with IRR and EPR. So as always, I'll just quickly go over the ground rules. Firstly, questions. You can ask questions at any point through the Q&A box. So on your screen, there should be an icon of a question mark inside a speech bubble. If you click on that, you can type in your questions. In there, you can also see the questions that other people have asked. And if there are any that you'd like to know the answer to yourself, then you can like them. And at the end, time permitting, we'll pose as many of the questions to the speaker as we can, starting with the most liked. And any that we don't get time to answer today will be posted to our events page. As usual with these webinars, you can use your attendance to count towards CPD points. So if you email the address on screen with the code shown, then you'll get your confirmation of attendance. That information will also be in the chat box in case you don't note it down now. And at the end, please send us your feedback. Feedback seems to have tailed off a little bit, but it is really, really important that we get all the feedback that we can so we know how we're doing with these webinars. So please fill in the survey link that you'll be sent after the webinar to let us know. So the SRP will continue its free webinar programme for the foreseeable future. We had a little break over the summer, but we're back now with a new and exciting programme of webinars. As I said in the last one, we are now a committee and we are really looking for new members if anybody would like to join. So if you're interested, please drop Charlene and myself an email. Another bit of news is that we have the second issue of Radiation Protection Today coming up. That will be released in December, I believe. So keep your eyes peeled for that coming out. Finally, I've got to plug membership. So if you're not already a member, then these are the benefits that you could be getting if you were. So as always, the Society Journal, weekly newsletter, and you're eligible for discounts for attendance to any of our conferences and full day events. You'll get to keep up to date with radiation protection, job vacancies, and get involved with the Society in general. So pop over to our website after the webinar to sign up if you're interested, please. And we also offer professional status. We've got these 3 levels of professional registration available. You can look on our YouTube channel. There are a couple of videos on there describing what they are and how you can apply for them. And we will be having a webinar on this topic shortly. So enough of me talking. Without any further ado, to introduce our speakers for today, I'd like to hand over to Professor Pete Cole, who is an SRP past president and the current president of AURPO. Over to you, Pete.
Okay, thank you, Sarah. I'm having a few connectivity problems, so I might drop out at any moment. But anyways, it's a pleasure to be here again and welcome everybody to today's webinar. And it gives me great pleasure to say that today's speaker is my dear friend and colleague, Stephen Green, who's going to talk about a subject close to my heart, which is radiation protection in veterinary practice. Steve started work with radiation in 1977, qualifying as a diagnostic radiographer in 1980. 22 years in the health service and education sector furthered his interest in radiation protection, and he entered the niche branch of radiation protection health and safety, becoming a fully certificated radiation protection advisor in 2005. Since then, Steve has obtained further certification as a radioactive waste advisor and a medical physics expert in diagnostic radiology. Despite being the founder and principal RPA and director of Stephen Green and Associates, Steve continues to be much involved with the practical application of the business of radiation protection. Steve also loves to teach on the many radiation protection courses offered by Stephen Green and Associates. So over to you, Steve, who's going to talk to us about radiation protection in veterinary practice and compliance issues with IRRs and EPR. Steve.
Am I unmuted now? Okay, thank you very much. Welcome everybody. To everybody that is here. Thanks for that introduction, Pete. Much appreciated. Your friendship over the years and your help has also been very welcome. Okay, so let's have a look at veterinary compliance issues with IRR and EPR. Where to start in some respects? It is a big subject, and I think that probably best to start right from the beginning. Veterinary professionals obviously use ionizing radiation, and they obviously use it for diagnostic radiological imaging, whether that be through the use of X-rays or whether it be through the use of technetium 99M for scintigraphy procedures, for example. I'll talk a little bit more about some of those in just a moment. Of course, we also do have to add on to that therapeutic administration, and again, that's therapeutic administration through linear accelerators as well as feline iodine 131 therapy. So yeah, their use is achieved by using a number of various applications. Let's take some of the X-ray equipment to start with, and I'll try and identify some of the issues that go along with that as we go through these images. Portable X-ray units. Portable X-ray units used in a static position. For those of you that are involved in veterinary radiation protection advice, you will recognise these. These are pretty commonplace in a veterinary practice, but they're commonplace also set up in X-ray rooms. So these are portable units which are basically strapped to the wall. The issues, well, issues are generally, a particular issue is that generally you expect veterinary imaging to be performed using a vertical or near vertical beam, but of course these can be taken off. And there is the odd veterinary practice out there where this sort of unit is actually taken off that wall mount and actually taken off site and used for off-site imaging in equine circumstances. We find on occasion that also there are some novel techniques which are used. For example, taking the X-ray unit off and then directing it horizontally for exotic animal imaging. Now, of course, that's an issue when we talk about when we come on to talk about things like shielding of a room, and you're dealing with a primary beam rather than a scattered beam. Static X-ray units. These are essentially examples, particularly on the middle and right hand side, of fixed static X-ray machines, generally ganged to digital imaging systems. Digital imaging has been an absolute godsend for veterinary practices. Fortunately, gone are the days where they have to have a dark room and it takes 5 minutes to actually process each image that they take. Issue. Sometimes actually the ability to get images very quickly can result in perhaps too many images being taken. It's easy to repeat if necessary. Dental, the obvious issue in relation to dental imaging is that the beam is much more able to be directed in different directions. Fortunately, tables, dental theatre tub tables are set up so that imaging would be conducted in particular directions, though. So again, if we go back to shielding, you'd be looking at various walls and not necessarily all of the walls when you're considering shielding. Some of the dental units can be set up in X-ray rooms as well. Biggest problem tends to be dental units that are proposed to be put into prep rooms in veterinary practices. Biggest issue with that, of course, is the number of entrances that we have into a prep room. So that can be quite awkward. Some practices do use handheld units. Mind you, there is good guidance out there. It's a little bit older now. I think it was produced in 2014, originally sort of in relation to sort of human dental uses. But vets have a good history of the use of PPE, for example. So again, in an appropriate room with appropriate training, the issues shouldn't be so paramount. Going on to Xray, equine Xray. On the left-hand side, fairly typical gantry-mounted type of Xray unit, much more powerful types of units than the example that's on the right-hand side there. And of course, some of those mobile units, example on the right there, actually are battery units. So they're charged up, taken. There is no electrical connection. One of the issues that we're finding with that is that some of those units are actually hybrid units. So sometimes they are plugged in. Another of the particular issues is what happens or what would happen if a unit such as that actually continued to expose. Can you get the battery out? How easy is it to get the battery out? Are you left with a situation where basically you just have to direct it at a wall and allow it to discharge itself through that? Fluoroscopy, quite a lot of theatres, certainly in veterinary hospitals, now have some form of fluoroscopy unit. Now again, there are issues with shielding, perhaps in some respects not such quite complex issues, because the primary X-ray beam is essentially almost completely attenuated by the image intensifier on the other side of it. So essentially you're dealing with a scatter problem with these sorts of units. Of course, people have got to be in close proximity to those units, so local rules and other safe systems of work have to be set up so that of course appropriate PPE is worn and conduct during exposures, so pieces of parts of anatomy not being in the beam when anybody is exposing. CT imaging has become more and more commonplace in veterinary circumstances. Shouldn't necessarily be a substitute for good general diagnostic imaging, but it is. They are very handy pieces of kit. Issues with computer tomography, of course, yes, there will be an issue related to shielding because of course these units are now using higher KVs. We're now up into the 130, 140 kV type range. There is also examples of equine CT units. The one on the right, again, you know, a large shielded block effectively around that equine CT unit. Probably one of the biggest problems, of course, is actually setting up the horse in such a unit. Perhaps the reason for the odd example of types of unit, such as the one on the left here, which is a standing CT, standing cone beam CT unit that's being developed in this particular circumstance. Lower doses, lower exposures from those types of units as compared to the if you're using sort of conventional CT. Linear accelerators, as I mentioned before, you know, therapeutic treatment via a linear accelerator. There are a few examples out there, and there are, we know, a few examples of Linacs being in the process of being built as well in certain veterinary hospitals. Obviously, the big issue here is that we are using extremely powerful beams in this particular case, and doses, of course, can be pretty spectacular. One of the issues, of course, is in relation to sort of dose limits and control of doses. Control of doses to the animals is something that's actually currently being considered by an ICRP committee in that situation. Equine scintigraphy, use of technetium 99M. Again, lots of different setups with these types of units. The one unit on the left and in the middle obviously one of the more modern types of units, much more adaptable than the type of unit on the right hand side. In fact, the unit on the right hand side is actually hanging by a chain from a gantry in that particular scanning suite. So yes, we're maybe talking about a radiation hazard to the horse, of course, but we're also talking about a physical and mechanical hazard in relation to the setup of that particular type of unit. Feline iodine 131 therapy, again, specialist setups, specialist requirements. I noticed a couple of those images are sort of actually on the setup on the side, which of course wasn't a deliberate action. But of course, now we're starting to of course, with scintigraphy and with iodine 131 therapy, we're starting to look at issues such as permit. Sort of application for permits as well as the use of it. Permits have obviously got to be appropriate for the use. What sort of disposal limits do you have? What type of disposal are you allowed? Will disposal be simply through solid route, or will there be an aqueous disposal component from it as well? We do have to bear in mind that veterinary work is actually a dangerous profession. Slightly shocked me to see this BEVA survey. BEVA is the British Equine Veterinary Association, where, as you can see there, 65% of equine vets indicated that they'd been injured in a year, 25% of them requiring hospital admission. They say never work with children and animals. Certainly suggests that working with animals can be particularly dangerous. Those 25% who required hospital admissions, you've got a range of injuries from just bruising through to fractures, through to actual sort of internal organ damage. Farm vet survey, as you can see there, indicated not much less in terms of injuries, and again, quite a reasonable percentage there having to actually take time off work. Now, is that a reason for, if we're talking going back to radiation protection, is that a reason for non-compliance? Well, of course it isn't. And myths still abound, and opinions and weird and wonderful phrases and statements still abound in that come from various users of X-ray units, for example. These are not just necessarily taken from the veterinary world. I don't need to wear a gown or gloves because I don't want any more kids. I've certainly heard that in the past. I have to say that sort of attitude is and has reduced considerably nowadays. It's the veterinary profession is becoming more of a younger. There are more younger people in that profession, and they don't seem to view, they don't view radiation in that type of way. Just to give an example, Sarah actually went to a veterinary practice when she was pregnant, and was doing some testing on an X-ray unit that was in a purpose-built X-ray room, well shielded door, lead glass viewing window as well. And a veterinary nurse ran up to her and said, "Why are you doing this? Surely you're not allowed to do this." Anyway, to do it more quickly, I'm not going to wear the gloves, just this once. Cutting corners, or the temptation to cut corners can obviously be an issue. Obviously, it's one of the things that's important for radiation protection advisors to get to instill the kind of radiation protection culture into veterinary staff to make sure that those sort of things don't happen. Is it because radiation exposure is easily ignored? Can't feel it, smell it, hear it? I'm not so sure that necessarily goes. Again, the levels of training nowadays do seem to be much greater. But sometimes do we close our eyes to things where we don't immediately know the consequences? Again, I'm not so sure that that's necessarily the case in the veterinary world, the modern veterinary world anyway, because of the training that they do receive in their colleges, and also on site, and also hopefully from the radiation protection courses that the likes of us radiation protection advisors are actually giving to them. It's really all about radiation protection culture. It's all about, well, we feel it's all about instilling a decent radiation protection culture in veterinary practices, helping them look at what they've got, what they need to do, and how they can do it, helping them ensure that they're trained properly, appropriately to an appropriate level for the type of work that they're undertaking. Helping them, get instruction from other areas as well. So, for example, can they use their CT scanners properly? Are they able to use the gamma cameras properly when we're talking about scintigraphy issues? Applications specialist training is obviously quite important in that. Now, there are professional guidance notes out there, as everybody's aware. They've been being produced back in the IRR 99 days, first set in 2002, and then a second edition later on. And of course, a couple of years ago, the latest iteration for IRR 17 was produced and released by the BVA, the British Veterinary Association. Essentially, isn't it? It's all about minimizing exposure. I've put suitable RPA appointment up the top, but we do think that advice from an RPA is a particularly important aspect in helping vets, veterinary staff, veterinary employers to make sure that they're minimizing exposures. Risk assessment, as is indicated all through the radiation protection world, is essentially paramount. Appropriate risk assessments identifying the appropriate measures for a particular practice. Generic types of risk assessment can be, shall we say, impractical in many respects. Veterinary staff who read generic risk assessments, actually, when they try to relate them to what they do, sometimes find that they simply can't do it. And that's the case also with local rules. Local rules have surely got to be appropriate for the work that's being undertaken in the practice. Again, generic local rules just doesn't work. Radiation protection supervisors, there is an issue at the moment in terms of the numbers being appointed. It's all about continuity of cover. There's a requirement for an appropriate number of radiation protection supervisors to be appointed, under the regulations. RPSs minimizing exposure. Well, if that's their primary role, to actually supervise the work that the staff are actually undertaking in a veterinary practice, then of course they'll be looking to see that local rules are being adhered to. Training really is, in our eyes, probably one of the biggest aspects. If you don't train people right, if you don't train people appropriately, mistakes are going to be made and they're not going to follow the rules, essentially. Put in there, including contingency arrangements. Yes, again, there is a requirement, and we know that there is, and we know that the Health and Safety Executive are indicating that, well, the regulations indicate that there needs to be some kind of rehearsal for contingency arrangements. Absolutely appropriate, particularly when you consider the contingencies when we're looking at the use of radionuclides. Spillages, contamination, for example. It's important to make sure that people are trained as to the highest degree possible before they actually start using radionuclides, and also obviously important to know what to do when things go wrong. Personal dosimetry, one of the big issues that's come in, or that has been around since IRR 17, of course, is the change to the iDose. So the need to examine the work area to determine whether in fact any kind of any leaded eye specs, for example, might be needed. So issuing appropriate eye dosimetry for certain periods to see what sort of doses are actually being received. But personal dosimetry historically is something that that veterinary staff and people in the veterinary profession are well used to, and we've tended to find there's not been a problem when we've wanted to when we've suggested and we've wanted to get some results from eye dosimetry. Use of PPE, again, historically PPE is used very commonly, in veterinary circumstances. Obviously, in many respects, PPE, if we're talking about small animal veterinary work, that's going to be inside, during conscious imaging, inside an X-ray room. Now, of course, there is a drive. I mentioned the guidance notes a couple of slides back, the veterinary guidance notes, and the veterinary guidance notes, indicate that it's less appropriate nowadays to actually do conscious imaging, and the amount of conscious imaging we're finding is actually reducing in practices. However, the issue is that in certain circumstances, it can still be seen as perhaps an easy way out to get a quick X-ray. So of course, it's important to make sure that people are actually using their PPE appropriately. Maintenance, well, I have to say, we have to say that as far as maintenance of equipment is concerned, it's rare to come across a veterinary practice where units aren't maintained at appropriate intervals. Generally, that is annually, and that includes the processing, all the processing equipment as well. Vets do tend to be pretty good at that side of things. Just have a look at another area where issues occur, and just to bring in, shall we say, perhaps other areas as well. Just to take the example of a new installation. Yep, of course, the regulations require that an RPA must be consulted for the prior inspection of plans. So looking at plans, helping with the design of engineering controls, lights, signs, etc. It's rarer nowadays, but it is still the case that we might visit a veterinary practice and suddenly find that actually they've put in a dental room, or they put a dental unit somewhere that we knew nothing about. It's again, it's instilling a decent, sort of culture of radiation protection to make sure that they're aware of the process that's needed, for this kind of installation. Engineers we find will still install, even if there is no plans report, no indication of engineering controls. It does surprise me why they would do it. They're supposed to know also that the primarily a radiation protection advisor has to be consulted in the first instance. And then we come to the critical examination and critical examination testing. Yes, installers, engineers who install, companies who install, they do seem to test the X-ray units before they leave. But it seems to us that there is one particular area that's missing. And of course, Regulation 32.2A2 indicates that that with a critical examination, you have to ensure in particular that there is sufficient protection for persons from exposure to ionizing radiation. So yes, it's about the Xray unit, it's about the Xray tube, it's about the Xray setup you've got, but surely it's also about the walls. It's also about the shielding that's been put in. Is that appropriate? Has it been looked at? Is there something that was needed to be there? It's something that we're finding is missing essentially from a lot of critical examinations. Why? I guess because the installers don't feel that that's necessarily part of their remit. I don't know whether that comes from something like the old IPEM guidance notes, with medical and dental guidance notes, where it's indicated that for a critical examination, the installer is not necessarily responsible for that sort of for that area of testing. However, those of course were medical and dental. There would be an expectation, certainly in a hospital, of course, that an MPE stroke RPA stroke MPE in a hospital would probably undertake that type of testing once going along with the installers. So critical examinations, acceptance testing, commissioning testing being undertaken in that sort of way. But of course, if we were talking about the veterinary situation, where does that happen? In that respect, it's important that radiation protection advisors, we think, ensure that that sort of testing is carried out on the room. So is there an element of RPA accountability that has to come into that? Now, we know that an RPA doesn't have to necessarily be involved in the critical examination, but if we're RPAs for the engineers as well, then we do feel that it is something that needs to be considered. Isolation. What type of isolators? Where are they located? Obviously, isolators inside a room are essentially inappropriate nowadays, particularly if it's a purpose-built room. In a room, fair enough, when people have to be in that room, fluoroscopy setups, for example, imaging in an equine stable, for example. So where is it located? Where is it best to locate it? It is important that we look at those sort of aspects. Signage, warning signs. I know there's a couple of images of warning lights there, and of course, there have been issues in the past with regard to warning lights. But warning signs are supposed to be correct. They're supposed to identify the nature of the hazard, for example. But there are other issues with warning signs, in that in the past, so often, and currently at the moment, we are still seeing so many signs which say something like you see on this particular slide. Authorized persons only. No entry when the red light is on. Well, when the isolator for the Xray unit in these rooms is turned on, that turns the warning light on. So technically, does that mean that those authorized persons can't go into that room to set up an animal? It's a little bit not joined up writing, shall we say. Signs, of course, under the regulations have to be appropriate. They have to identify the nature of the hazard. We think putting an indication of who the radiation protection supervisor is at the bottom, of course, it helps as well. It gives a contact. What about the RPA? Are there issues with RPAs? Yes, RPAs, RWAs. I mustn't forget the radioactive waste advisor, because we're talking about EPR compliance as well. Suitability of a radiation protection advisor or a radioactive waste advisor. Of course, they've got to be able to They've got to be able to adapt the advice and give advice in that particular area. So there has to be a certain amount of experience. So do they have experience with the use of X-rays? Do they have the experience with the use not only of X-rays, but the use of X-rays in a veterinary situation? Another issue in relation to radiation protection advisors and radioactive waste advisors is sometimes their availability. So often we hear in a veterinary from the veterinary profession, but we've struggled to get in touch with our RPAs or our RWAs. And of course, things happen, and things happen that veterinary staff want to contact and get in touch with an RPA or an RWA as soon as they possibly can. And of course, if we're talking about RPA and RWA suitability, we've also got to be talking about RPA and RWA accountability as well. Yeah, surely we've got to be accountable for the advice that we give. I don't think that's inappropriate. It's surely the professional thing to do. You notice the comment on the bottom there. That's the last thing we want a radiation protection advisor or radioactive waste advisor for people to be talking about them there. A billing exercise rather than a constructive improvement exercise. That's not what an RPA, that's not what an RWA is all about. Of course, that goes as much with on the enforcement side. Now, obviously, inspectors, health and safety executive, environment agency, they're all trained, and they're trained to be suitable and available and accountable, of course, for the enforcement action that they take. Just to take another area, and I talked about non-generic documentation being appropriate for the particular use. Just to take this particular example, designation of an area on-site, off-site, the use of cordons and signs. How is that particular veterinary practice? What is the best way for that particular veterinary practice to use those particular cordons and signs? Where are they going to aim their X-ray beams? Towards a physical barrier? What's going to happen? Are they going to be doing these in a stable? Do they need to use shielding behind the cassette? These are the sort of areas that the RPAs can be particularly helpful in giving advice. But the problem with that is, if you don't see it, you don't know what they do. We always work to our little mantra, which is, if you don't visit, you won't see. Now, a question was asked in the AURPO conference to Stuart Robertson about radiation protection advisors, radioactive waste advisors, of course, that applies to as well, visiting practices, and it was said, yeah, absolutely, and of course, if people are doing it by questionnaire, if radiation protection advisors, radioactive waste advisors might not be visiting, then they've got to ask the right questions. It can be difficult to ask the right questions if you don't know what they do. Just concentrating a little bit on some EPR issues now. Cradle to grave. The principle of cradle to grave is, again, is obviously paramount in terms of compliance with the use of radionuclides. Issues for the veterinary users. With centigraphy, one of the things we found is the breach of permitted holding levels, not because they've ordered too much, but because it's been delivered at the wrong time. And when the isotope has been delivered, it's been over their permitted level. We picked up a couple of these a couple of years ago, and that came from auditing the documentation at the particular sites. So of course the Environment Agency had to be contacted. Nowadays, now how we work with those vets that are doing this is that they have to have more, shall we say, robust methods of the isotope arriving on site. So much so that in fact one of the practices rang us a few weeks back and said, I've got a van driver outside here who's really angry with me because I won't let him drop off his isotope, but I've calculated that it's over my permitted limit. What shall I do? My simple answer was let him wait. And in fact, if you like, take the phone to him and I'll have a word with him. By the time he got back to the van driver, he'd had a word with his employers, and he told the vet that he was happy to wait. It is something that they do need to take account of. It's important to have all those processes. So procurement, delivery, storage, security, all those sorts of areas are just as important as the actual use of those particular radionuclides. New updated procedures, bringing in something new, is something that obviously needs to be taken particularly seriously in the veterinary profession. Of course, you've got to go back to risk assessments. You've got to go back to how do you adapt your local rules? How do you adapt your systems of work? How do you adapt your permits sometimes as well? It's important that the veterinary profession keep in touch with the radiation protection advisors, radioactive waste advisors in that sort of situation. And again, training. And again, I've highlighted, I've bolded the training in that particular side simply because training helps people get it right. Training helps stop people getting it wrong. Again, but it's training again, right from this cradle to grave principle. Who is going to be trained up appropriately to receive on, or who's going to be trained up appropriately to actually order the radionuclide? Who's going to be trained up appropriately to receive it on site? Again, we've had situations in the past where radionuclide has been essentially left outside a practice because nobody was there. Of course, that should never happen. As far as I'm aware, that's never happened. I don't know how apocryphal that type of story is in that situation. But again, it's important to make sure it's done. Yeah, we've got to talk about waste because yes, it's got to be used. There've got to be safe practices, safe systems of work through the whole of the administration, the use, whether it be the therapeutic use or of course the imaging use of the particular radionuclides. And then of course there's got to be compliance with the waste aspects as well. It's interesting that it's nice to be able to give the veterinary profession good ways in which to look at the processes. And this is a particularly good one, or we feel it's a particularly good one, that came from an environment agency, RASCAR. So plan, do, check and act. And it's something that we're currently using, not just at the practice where it was originally indicated, but it's something that we're using and looking at in terms of the other practices that we use as well, that we look after as well. There's no point reinventing the wheel. And if it helps their compliance, it's got to be good. Training, back to training again, IRR and EPR, of course. General awareness training, making sure that people have an awareness if there's radiation any source of ionizing radiation being used on site. Radiation protection training, basic radiation protection training, a little bit enhanced to become radiation protection supervisor training as well. Then of course, if we're talking about the use of X-ray machines, talking about the use of radionuclides, the training of those who are going to be authorized users as well. And that's the practical training of how to use an X-ray unit properly, practical training of how to relate the local rules to the X-ray equipment that you're going to be using, and all the way through to things like contingency rehearsal, as I mentioned before. Not only that, yes, of course, is it being conducted? What areas is it being conducted in? but also, is it being documented? We all know that if it's not written down, it doesn't exist. So it's important to make that vets do actually indicate that they are undertaking this training. Okay, and that leads, and I only want to spend a couple of minutes on this, but it is perhaps a big issue that is currently going around in terms of general classification of users of radionuclides in nuclear medicine. But I just wanted to look at a couple of slides in relation to the classification of veterinary workers who are actually undertaking iodine 131 therapy for cat hypothyroidism. And the one thing I would say is that there is a big difference between users in a veterinary situation and those users in a hospital situation. Vets use somewhere between 70 and 140 megabecquerels to inject. That's probably less than a tenth of the levels of activity that is actually used in the human medical circumstances. So that's our sort of base aspect and our base level. There's the regulation, and just a couple of comments about that. As far as regulation 21 is concerned, yes, it's employees who are likely to receive an effective dose greater than 6 millisieverts per year. Going on to the ACOP, and particularly in ACOP 433, the employer should designate as a classified person any employee, etc., etc., where it's reasonably foreseeable an employee could receive an effective dose greater than 20 millisieverts or an equivalent dose in excess of a dose limit within several minutes. And again, the regulation 21 guidance to decide an employer can take account of past doses received by the employee. So I've just highlighted the words likely and should and within several minutes because I'm confused. And to me, that's where the issues are. So I don't know, at the end of this, perhaps we can go, it can be, my confusion. I don't know whether it will be allayed or whether it can be helped. But other thing I will say about this is notice the little red highlighted area there. This is the same regulation that was in IRR 99. It's the same now in IRR 17. The only difference actually that I can see is that little comma that comes after 20 millisieverts there. So essentially we've got the same regulation over two sets of regulations, but I'm not aware of any need to classify through IRR 99. I'm not aware actually of any need to classify in the first few years of IRR 17. The veterinary guidance notes were also issued just a couple of years ago. There's no indication in there for any need for classification. So again, I'm confused. I'm confused by the definition in relation to likely. And these are legal definitions here. So likely, essentially, there is a strong probability. Should means an action is desirable, but not mandatory. So it denotes a guideline where non-compliance with the specification is permissible. I'm not suggesting that we deliberately don't comply. I agree with classification, and I certainly agree with classification where it's appropriate. But I'm confused also because of the grey highlighted area there, where it says within several minutes. More about that just in a moment. The definition of several is more than two, but not many. So is it likely that those dose limits will be exceeded? Well, here's the maximum individual annual doses recorded at a particular iodine 131 feline therapy unit that we actually advise. There's nothing that approaches the sort of levels that's indicated in the regulation. I could go into calculations. I'm not going to, because I notice it's 10 to 1 for starters. So I'm a little bit past my 45 minutes, and but just bear with me for another couple of minutes. You can do calculations. In view of a couple of notices of contravention that have just recently been issued to a couple of vets that we act as radiation protection advisors and radioactive waste advisors to, there has been this, it's been indicated that those staff should classify. So we've revisited the risk assessment. The risk assessment, there are a couple of quotes in the actual notice of contravention in relation to the old risk assessment. One of them is in relation to a committed effective dose. Well, that's not a dose within several minutes. There's also a relation to a dose limit being exceeded, but it's in relation to the 20 millisievert dose limit and not the extremity dose limit, not the extremity equivalent dose limit. So again, I'm confused. Why classify? Well, why do we classify? I can understand, perfectly understand, as I said, why we classify high dose uses of sources of ionizing radiation. However, if we're talking about, again, if we're talking about iodine-1 therapy, iodine-131 therapy, those users are using PPE, appropriate PPE. They're working under really quite strict systems of work and local rules. So they've got those checks and balances in place. They're not outside workers, so they aren't required to have a radiation passbook. And of course, the other area that classification brings in is the need for a medical. But again, I'm confused about that. Why am I confused? Particularly because of the IAEA Safety Report Series 104, whereas you can see at the bottom there, it actually states no specific workers' health surveillance relating to radiation exposure is necessary for staff involved in veterinary nuclear medicine. So again, I'm confused. Now, just as with the Environment Agency, again, we try and look for good, good ways in how to explain and how to understand. This classification flowchart actually comes from the HSE website. Again, yes, it relates to the taking account of possible accidents, but again, it also relates it to this 6 millisieverts per year or equivalent doses, those appropriate equivalent doses being likely to be greater, those doses being likely to be greater. The risk assessment, in a nutshell, the revised risk assessment that we've produced indicates that those workers in feline iodine-131 therapy procedures don't need to be classified. So why do they need to be classified? Why, as in one of those notices of contravention, it actually says that you should revise your risk assessment to indicate the need to classify your workers. I'm confused. And folks, that's it. Thank you very much.